we will be seeing a lot of cases in the OP, wrist pain, hand pain, and also you will get some short cases, mainly of a wrist drop or a claw hand or deformities or CRPS, something like that. So it's very important for you. So before, you should do a screening before starting the exam. So ask the patient to keep the hand over the table. Then look whether the cascade is normal. Okay, so what is a normal cascade? Normal cascade means the little finger is more flexed than the ring finger. Ring finger is more flexed than the index finger, middle finger, and middle finger is more flexed than the index finger. So this is the normal cascade. Then ask the patient to flex and extend. So this is the normal routine screening that you should for any case with hand and wrist pain. So suppose the cascade is not normal. Suppose the patient is having hand like this. What does it mean? It means if the sensor is normal, it means there is injury to the flexors. It may be a flexor tendon may be injured. That is the reason it is like this. Suppose it is keeping like this. The patients may be having a dupitus contracture. Okay. Suppose there is MCP extension, that is maybe he is having a claw hand. So look, the cascade is normal or not. So that is the screening. Then what to do? So the most of the cases you will get are nerve injuries, CRPS, deformities and all. So I will be dealing with nerve injuries and deformities. I don't think I can cover CRPS in half an hour all this. So in nerve injury, what is important? History is very important. You should know how the trauma occurred. What is the mechanism of trauma? Then whether it was a compression injury, whether it is a stretch injury, or an open injuries. So what is a compression injury? Maybe it is a neuropraxia. So a neuropraxia, the recovery takes around 4 to 6 weeks. So because there is only a physiological contraction block only. If it is a stretch injury, it can be an axonotomesis. So what is the difference between axonotomesis and a neurotomesis? Axonotomesis, the connective tissue sheaths may be completely or partially maybe there. Okay, so the chance of recovery is there. Actually, the axons can grow. After Valerian degeneration, the axon can grow at the rate of 1 inch per month. If it is a complete axon loss. Of a partial nerve injury, patient can have recovery by axonal sprouting. So recovery is possible even without a surgical intervention. But with neurotomesis, what happens? A surgery is must because it may be retracted and open surgery will be needed. So we will deal with, first we will deal with the radial nerve. Okay, so you can have, it is arising from the posterior cord of the brachial plexus. So you can have lesion at the axilla, you can have lesion at the spiral groove or just below it or below elbow, that is the pin palsy. Okay, so if it is the axilla, how will you differentiate between axilla and spiral groove? The triceps are involved. In an axillary lesion, the triceps are involved. Okay, so if it is a spiral groove, what happens, or below spiral groove, because then brachioradialis may be involved and also the extensor carpi radialis longus. Okay. So in a typical wrist drop, what happens? You should look for the power of brachioradialis. Okay, then ask the patient to be prone and give pressure and you just feel for the muscle. That is very important. Feel for the brachioradialis. Then this is the pin palsy. Usually we get the pin, there is no motor, there is no sensory component, only motor. Okay, usually in the between the supinator it will become compressed, or you can have demyelination there, something like that. So they are pure motor. So this is known as Texas Longhorn sign. This is the Texas Longhorn sign. Okay, so because the middle finger and the ring finger is completely involved and the index and little finger is partially involved. Why it is like that? There are different explanations. Maybe the recurrent branch of posterior dorsal nerve may be partially involved. Okay. So patient will get a partial wrist drop because why? Only there will be partial wrist drop. Why? Because extensor carpi radialis longus is paired. So patient can have like this, a partial wrist drop and finger drop and a thumb drop also. Then another compression is known as Wartenberg compression, that or chiralgia paresthesia, where a sensory component of the radial nerve is only involved. So these extrinsic muscles of hand, that is 6 compartments, and examiners are very fond of asking that what is the tendon in the first compartment, and most of the time you will falter. I will tell a mnemonic. All peanut lovers eat peanut butter. All peanut lovers eat peanut butter. Okay, that is APL and EPB. That is difficult for some of you too. So you just learn this mnemonic. So that's first compartment. First compartment is APL and EPB. Then second compartment, extensor carpi radialis longus and brevis. Oh, it's like that, longus, brevis, like that. Okay. Then extensor pollicis longus. Then come extensor indicis, then extensor ditorum communis, then extensor ditae minimi. Okay. And extensor carpi ulnaris. No. Okay. And also you should know how to test this muscle, because clinical examination, in clinical exam you will ask to test these muscles. How to test extensor ditorum communis, how to test abductor pollicis longus, all this. Okay. So while doing extensor ditorum communis examination, ask the patient to just flex the IP joints, because the intrinsic muscles of the hand will extend the IP joints. So to nullify that action, ask to flex the IP joint and give resistance like this and look for the tendons. Okay. Then EDC. EDC is an extensor indicis proprius. Extensor indicis is an important muscle for EMG, for doing an EMG and all. Why? Because to differentiate between a CAT1 lesion from a combined ulnar and median nerve lesion, you just do an EMG of the extensor indicis proprius. Okay. So how to test that muscle? You nullify the action of the other EDC by ask the patient to flex the other fingers and then give pressure here. This is how you test for extensor indicis proprius and extensor indicis, extensor ditorum minimi. Then how to test for extensor pollicis longus? Ask the patient to keep the hand over the table, then give pressure like this, and the standing that tendon which stands out, the anatomical stuff wall lateral to that anatomical stuff wall, that is EPA, extensor pollicis longus. It forms the boundary of the anatomic stuff blocks. Okay. So that is about the radial nerve. Then what about the ulnar nerve? Ulnar nerve, you will get the typical claw hand deformity. So in claw hand, what is the thing that is happening? There is hyperextension of the MCP joint and flexion of the IP joints. And another important interesting question that examiners ask is, what is an ulnar paradox? Okay. So what is an ulnar paradox? Usually in a higher lesion you think that the lesion will be more severe than a lower lesion. Okay. But here in an ulnar nerve palsy, what happens? A lower lesion is having more deformity. Why that is? Because why is it? Because in a lower lesion, what happens? The FDP, flexor ditorum profundus, is spared because the innervation is from high. So FDP is spared, that will produce flexion of the IP joint. So you will get more deformity. Whereas when the patient is having a deformity lesion in the above the elbow, what happens? The FDP is involved. Okay. So when the lesion is high, what happens? The FDP is involved. So what happens? There won't be flexion of the IP joints. So that is an ulnar paradox. So suppose the patient is having a lesion at the elbow joint and you are treating the patient, and when the patient is recovering, his deformity is increased. So he may see you, or he may think that due to your treatment the patient is worsening. Okay, so that is a paradox. Then palmar and other intrinsic muscles of the hand, which are intrinsic muscle. It is not only the palmar and dorsal interosseous, then there are the thenar muscles and hypothenar muscles. Okay, so palmar and dorsal interosseous, there are 3 palmar interosseous. And what is the action of palmar interosseous? It is adduction. Palmar interosseous adduct and dorsal interosseous abduct. Okay, and the nerve supply, ulnar nerve. Okay. Then there are the lumbricals. What is the action of the lumbricals? It is the flexion of the MCP joint, and lumbricals are unipinnate, first and second. From which nerve is the nerve supply of lumbricals? 1 and 2 is median, 3 and 4 is ulnar. 1 and 2 me, 3 and 4 u. That is the mnemonic. Okay. So you have to test. Is this a proper way of testing? A cart test for the intrinsic adductors. What is wrong? You should not do like this. Okay, you should use the finger which the patient is using. He is using right hand. You should use also right hand. And if it is index and middle finger, you should also use that finger. Okay, then give force. Don't do like this. So this is the correct way of doing a cart test. This is Wartenberg sign. Okay, what happens in an ulnar nerve palsy? There will be abduction of the little finger. Why? Because the palmar interosseous is weak and these extensors will overact. What is this Fromet sign? What is the reason for Fromet sign? In which nerve lesion will you look for that? What happens in Fromet sign? It is for ulnar nerve lesion. Okay, you ask the patient to grip between the thumb and index finger. So when there is weakness of the adductor pollicis, what happens? The patient will use abductor pollicis longus. Okay, so that is Froment sign. Then median nerve. Median nerve actually it arises from the lateral and middle cords, and it has no branches in the arm. In forearm, you can have lesions, pronator Terry syndrome, you can have lesion, then you can have anterior nerve, anterior interosseous nerve palsy. Okay. So, and if the lesion is above the wrist, this palmar, superficial palmar cutaneous nerve is spared. So you look for a sensation of the thumb. Okay. And in the carpal tunnel, since this palmar cutaneous branch is going above the retinaculum, it is spared. So test for median nerve is the pen test. This is the abduction, palmar abduction, and you look for the abductor pollicis brevis by just giving pressure here. Okay. And suppose you are getting wasting of the thenar muscles with normal sensory, don't think it is CTS. Okay, what it could be? There is weakness of abductor pollicis brevis with normal sensory. Do you think it's a motor median? Think of CA-T1 lesion. Okay, because abductor pollicis brevis T1. So look for a sensation in the T1 area. Okay, also it may be a cervical rib. I have seen so many had done CTS release for a CA-T1 lesion in the cervical rib. So when there is a gross weakness with minimal sensory loss, double check. Look for a CA-T1, a cervical rib, or any cause for a neurogenic TOS. This is the OK sign. OK sign, this is OK sign. Okay, so what happens? When there is weakness, you won't get this OK sign. And when there is weakness of the FDP. Then this is the pointing index. Why pointing index? Median nerve supplies the first and second FDP, flexor determined profundus first and second is supplied by the median nerve. Then why are you getting only a pointing index? Why there is no pointing of the second? FDP lies in a separate sheath. Okay. And other three lie in along with the ulnar, it lies in another sheath. So when you are flexing the ulnar FDP, this also will get flexed. That is why you are getting a pointing index, even though FDP 1 and 2 is supplied by the median nerve or anterior indocious nerve. Okay, it is by the anterior indocious nerve. FDS is by the median nerve. Then how to test for this is also very important. The mistake you usually make, how to test for FDS. Always extend the other two fingers while testing the FDS. Okay. Then FDP, you do it like this and give pressure here. So eliciting the clinical signs is very important. Then this you all know, Phalen's test. Okay, for CTS, there is Phalen's test is there, reverse Phalen's is there, then compression and flexion, and the Tinel sign. Where to look for a Tinel sign between the flexor, where to look flexor carpi radialis and the palmaris longus. Okay, but that's like the median nerve. So that is about the nerves, ulnar, median and radial. Then we will look at the wrist pain. Wrist pain also very common, and always it is just like this small area. There will be bones, there will be ligaments, there will be tendons. So someone comes with a wrist pain, don't do an MRI straight away. In MRI you will get a TFCC injury on MRI, but that may not be the cause for the wrist pain. A 40-year-old patient come with wrist pain, do an MRI, he will definitely have an TFCC injury, that is triangular fiber cartilage injury, complex injury. Okay, but the cause may not be that. So don't give PRP there and send the patient. Okay, so it is very important to look for the, just like a back pain, you should look for the pain generators, which is the cause of pain. So that is where palpation is very important. So there are so many things to palpate in the wrist. So what are the causes for radial side wrist pain? One is decurvent tenosynovitis, the first compartment, abductor pollicis longus and extensor pollicis brevis. Then the intersection syndrome, that is just 5 centimeter distal to that you get the intersection syndrome, where the tendons, abductor pollicis longus and extensor pollicis brevis will cross over the extensor carpi radialis longus and brevis. So always palpate, then look for the snuff box, look for the scaphoid tenderness. Then go up, look for the first CMC joint. Okay, so palpation is very important. So this is the test for decurvence. There are Finkelstein's test and Eichhoff's test. So don't confuse. These are two different tests. And Finkelstein is more sensitive. Okay, so just to give a traction, then flex it. Then just ulnar deviate. So that is Finkelstein. In Eichhoff's, what are you doing? You are just keeping it like this and keeping and giving a ulnar deviate. This is more painful in normal hands itself. So it may not be positive. There can be another causes for this wrist pain. So Finkelstein is more sensitive. Then there are other tests also, I think Watt's test, something like that also. But examiners will definitely ask this finger test, Finkelstein test and Eichhoff's. Then cause for central wrist pain. So most you should look for the that is scapholunate ligament injury. So just palpate the Lister's tubercle, then you will get a soft spot there. soft spot. That is the area of the scapholunate ligament. Then another thing is Kienbon's disease, cause for central wrist pain. Then dorsal radioulnar joint dislocation or pain or subluxation like that. So this is the Ballotman test for dorsal radioulnar joint dislocation or pain, subluxation. Then this is Watson's test for this stability, this scapholunate, that's instability of that scapholunate ligament instability. Okay. So what you do, you keep the thumb over the scaphoid tubercle, then your index another finger over this soft spot in this area just above the listus tubercle, then ulnar deviate, extend, then go like this, radial deviate and flex. You will hear this scaphoid will subluxate and that will produce a clunk. So compare it with both sides. So that is for that instability. Then ulnar side wrist pain, this is common in our very practice. Most commonly it will be an ECU tendinitis, or it could be an triangular fibrocartilage complex injury. So look for that. This is a fovea area, that is soft area here, fovea between this ulnar styloid and the pisiform. That will be tenderness. Okay. Then look for the tendinitis of extensor carpial ECU tendinitis also. Similarly, anteriorly also you can get this pain or the flexor carpi radialis tendinitis, pisiform, test for the this pisiform bone. Then sometimes hookup hamate also, sometimes fall on hand, outstretched hand. So always ask for the mechanism of injury. That is very important. So by looking at the mechanism of injury, you can identify whether it is a ligament injury, whether it is a bone injury, and the amount of trauma, amount of the injury you can assess. So always look for the mechanism. That is about TFCC. And another very important question for examiners are very fond of asking is piano key. What is piano key sign in rheumatoid hand? Then the common deformities that we see in our practice. One is a botanier deformity, swan neck deformity, mallet finger, intrinsic plus, lumbrical plus, gamekeeper's thumb. Okay. So what is a botanier deformity? Botanier deformity is because the central slip is injured. Okay, so you will get flexion at the IP joint and hyperextension of the distal interphalangeal joint. This is the botanier deformity. Okay. So what test you will do? You should do the Elson's test. So ask the patient to keep it like this. Then you give pressure. So when there is central slip injury, what happens? This won't be supple. Okay, because when you are giving pressure, the lateral slip will be holding this. So the distal phalanx won't be supple. So that is how you diagnose a central slip injury. That is known as Elson's test. Then the swan neck deformity, usually due to the injury to the volar plate. So patient will have hyperextension of the interphalangeal joint and flexion of the DAP joint. That is known as swan neck deformity. So in rheumatoid hand, you will get as a short note, or you will get for a short case, as a short case also. Then mallet finger, where there is an avulsion fracture of the extensor tendon, or it may be a bony mallet also, sometimes a bony chip will be avulsed. Then what is intrinsic tightness? So some injury and all, when you can produce intrinsic tightness. So how to test that? That is known as a Bunnell's test. So whenever you hyperextend, this flexion, IP flexion is equal in any position of the MCP, whether it is hyperextension or flexion. IP flexion is normal. Okay. So when there is intrinsic tightness, what happens? When you are extending the MCP joint, the IP flexion will be restricted. And when you are flexing the MCP joint, because of the loose fibers, you can do it easily. So that is known as Bunnell's test for intrinsic tightness. Then another deformity that we commonly sometimes falls on outstretched hand, or sometimes this is a chronic repetitive injury that is known as gamekeeper's thumb. So gamekeeper's thumb is actually a chronic repetitive injury producing of this ulnar collateral ligament. Okay, suppose it's an acute trauma of a fall like that, then that will produce a skier's thumb. So both are same mechanism. One is a chronic repetitive stress, other is an acute injury. So a gamekeeper's thumb, usually how will you test it? Usually both there are two ligaments, ulnar collateral and accessory collateral. So when it is an extension and you are giving a valgus force, then both will, when that is opening up, then both is involved. Suppose you are doing it at 30-degree flexion, then only the ulnar collateral ligament is involved. You give a valgus force. That is known as gamekeeper's thumb. So these are some of the deformities and some nerve lesion only. Okay.
In examination of the wrist and hand function, I think it's also good to include that grasp, pinch.
Yes. Pinch and all. That also, I think I got on 30 minutes, so I think I couldn't cover it.